So I'm going to talk about what changes I have made in vitrectomy for retinal detachment. For more than 2 decades, when I started my practice, we tried pneumatic retinopexy and gave it up, as we told you just now. Scleral buckling was the commonest surgery done for retinal detachment. Vitrectomy was reserved for complicated PVR patients, or when the scleral buckling was not possible, or when the scleral buckling failed. So vitrectomy was almost always combined with scleral buckle in these kind of situations. So it was almost a combined buckle vit. But what has changed now in the last decade, vitrectomy has replaced scleral buckling as a primary surgery for retinal detachment in my own practice. And these days, I hardly ever combine scleral buckling with vitrectomy, even in patients with PVR or giant retinal tear. And of course, scleral buckling can now be done with chandelier instead of wide angle, with a wide angle system instead of indirect ophthalmoscopy. So why this change? We know that vitrectomy machines have improved, the cutter technology has improved, MIVS has made a vast difference in terms of fast healing and faster surgery. The wide angle systems have allowed us to examine the peripheral retina much better and do the vitreous surgery at the base much better. And I personally think that a patient for the retinal detachment, vitrectomy is a more rational treatment for retinal detachment than scleral buckle, because in vitrectomy, you are able to relieve the vitreoretinal traction permanently. You are able to get a retinal reattachment on the table, and you are able to get a retinopexy on the table, which works within 24 to 48 hours by your laser. The retina is already attached. So for all these reasons, I think the vitrectomy is a better option. But when it comes to vitrectomy for uncomplicated RDs, like we started off with vitrectomy for complicated RDs, but when we switched over to started doing vitrectomy for uncomplicated RDs, we have to make certain changes. We have to make it a minimalistic rather than an aggressive approach like what we used to do for a complicated RD. So I have made many changes in my approach, and that's what I'm going to share with you. Now, whenever I start vitrectomy for a simple RD, the aim is to peel the vitreous to the periphery, and do a good core vitrectomy, relieve all the traction around the breaks, flatten the retina enough to get laser around the breaks, and use a short-term tamponade like gas. So my changes are, I don't do aggressive vitreous skirt excision anymore. Earlier, when I used to do vitrectomy, when I used to do skirt excision with depression, I used to create at least 2-3 breaks during this step, trying to be aggressive in removing that skirt of vitreous. But these days, I don't. I hardly get any breaks because I am not so aggressive. And having said that, it's important to remove the traction around the breaks very well, especially around the horseshoe tears. It is important to do a good vitrectomy at the skirt and remove all the traction, especially on the flaps of horseshoe tears. In fact, I even remove the flap of the horseshoe tear because it ensures complete removal of the traction, and also otherwise the flap causes problem during your fluid air exchange, occluding the soft-tipped cannula. And I do not use PFCL whenever I'm operating on an uncomplicated RD, unless when there is vitreous is not detached completely and it's difficult to peel the vitreous. Only in this situation I would put PFCL posteriorly to hold the retina and do PFCL assisted vitreous-based peeling. And I always do a fluid exchange before I do a fluid air exchange, because this flattens the retina and makes the fluid air exchange faster. And extendable soft-tip cannula is one of my favorite instruments to drain SRF, especially from a peripheral break. And this is one of the reasons why I don't need to use PFCL in my own approach to vitrectomy for RD. And earlier, I used to have a mental block for creating a drainage retinotomy. I used to bend over backwards, try to drain the SRF from a peripheral break. But now, if there is a pocket of SRF, which is sequestrated posteriorly, which cannot be drained and which has to be drained, I don't mind doing a small retinotomy, posteriorly. And here, I just treat it with a gentle laser, with a single row of laser, rather than 3-4 rows of laser like what we do in the peripheral breaks. So I don't shy away from doing a drainage retinotomy. And I also realize that it's not necessary to drain all the fluid. We can afford to leave behind a shallow fluid, behind, and as long as you get the breaks flat on the retina at the periphery so that you can do the laser, you can get away with a shallow fluid posteriorly. And we laser only the breaks and the lattice. Initially, when we started vitrectomy for simple RDs, we used to do 360-degree laser because we were afraid, because we are not doing a buckle in a phakic eye, we were afraid that, it might redetach or something like that. Therefore, then we realized that it's not necessary, and we did a study. We found that the results are same whether you do 360-degree laser or whether you do laser around the breaks only. And I do not do ILM peel in simple RDs. I do only if there is a PVR component in that eye. Only in that situation I do an ILM peel in these eyes. Some of the myths that have been broken especially relate to the inferior breaks. Inferior breaks, this was what I thought, and we practice inferior breaks need support by a buckle even when doing vitrectomy. This is not so. Even simple vitrectomy alone without buckle can flatten an inferior break RD. And second myth we practiced was gas cannot work in an inferior break RD. No, that's not true. We have managed many patients with an inferior break RD with gas alone and no buckle, and it has worked. In fact, we presented a series of patients managed by this technique both in ASRS and in VRSI. So it does work. So it's not necessary to use silicone oil or an inferior buckle in an inferior tear RD. Just to show you through 2 videos, and I wind up my talk, this is just to show fluid drainage. Here you can see that I'm just aspirating the fluid. I always do aspiration, active aspiration with my soft tipped cannula. There is no passive aspiration. All my aspiration, whether doing fluid air exchange or any procedure, is always active, foot pedal controlled. And you can see that the retina has flattened considerably with just fluid exchange. And then when I switch over to fluid air exchange, the retina flattens very fast. And this is also a very good way to get rid of the fluid from the posterior pole itself, much more easily. So fluid exchange is an important component. Here is my favorite instrument, extendable soft-tipped cannula. This is introduced through the peripheral break, and then the silicone tip can be extended backwards to go into the pocket of subretinal fluid posteriorly, as you can see. You gently insert. I can see that there is near the disc, there are 2 pockets of SRF posteriorly. So now I have introduced the extendable soft-tip cannula posteriorly and start gentle suction. So do not use high suction, use low suction, because if you use high suction, what happens, the SRF near the tip of the cannula comes to the cannula, and then the retina flattens and the fluid gets sequestrated in the posterior pole. Use low suction and gently allow all the SRF from the posterior pole to come to the tip of the cannula, and gradually you can see how the retina has flattened, and we were able to flatten the retina with this extendable tip cannula. And once that is done, you withdraw, and you see always a track left by the cannula, because it has gone into the subretinal space. It rubs against the RPE, and a track is left behind, but this doesn't really matter. The last video is about incomplete drainage of SRF. This is a patient who had a retinal detachment. There's a core vitrectomy being done. This is a peripheral break, and we started draining SRF through the peripheral break. I did not use an extendable cannula here, and we were able to drain the fluid in the periphery quite well, and we were able to do a laser to the breaks. You can see that I'm able to do laser to the breaks in the periphery and the lattice. There was a small shallow SRF left behind. You will see at the end of surgery, I'll just show you. So you can see that there in the posterior pole, there is a shallow SRF that's left behind. And we just left it, and then this patient's retina flattened. And in this particular patient, we put the patient face down in the initial period, although the break was superior, because we wanted the SRF to be cleared from the macula first. So we put the patient face down, and then within the 24 hours the retina flattened. So you can leave behind a shallow layer of SRF in the posterior pole, but bear in mind, if you leave a large balloon of SRF, you might have retinal folds. That is something you have to be very careful. So in conclusion, vitrectomy has overtaken scleral buckle as a primary surgery in my own practice, and I think this is true for all of us today. But what you have to realize when you are doing vitrectomy for a simple RD as opposed to a complicated RD like a giant tear or a PVR, aggressive steps are not needed. The goal here is minimal intervention required to get maximal results, and therefore all of us have to practice some kind of a restraint. At least I had to practice some kind of a restraint when I started doing vitrectomy for simple RDs. Thank you. I hope I have shared some of my changes I have made and the reasons for them, and I hope it helps you in your day-to-day practice.